Very good afternoon. We'll be starting. So you can start off.
So, Dr. Yogesh sir, he'll be speaking on refractive error management in children.
पॉइंटर है
Over to you, sir.
कहाँ है पॉइंटर किधर है देयर इज नो पॉइंटर यार अच्छा इसी से कर लें अच्छा। चलो जी सो गुड मॉर्निंग टू यू ऑल आई थिंक इट इज आफ्टरनून सॉरी सो आई विल स्टार्ट ओके Now, refractive error management in children is a different art. It's a different cup of tea against an adult refractive error. You see, actually, this is a full. We had IC in All India conference also twice on this refractive error. पूरा 1 घंटे का है, तो ये 8 मिनट में हो नहीं सकता. But you know, I'm just going to. That's what I was telling you. You should be a member of this. Now, for ease of understanding and management, the format is divided into 2 groups, birth to 8 years and 8 to 16 years. Now, you should also understand what is e-metropisation, because this is the first step if you go towards the refractive error management in children. Now, e-metropisation is a natural process. By virtue of the anatomic changes, the eye assumes a state of no refractive error. Is it clear? So then, now there is a general agreement that most infants are hyperopic, and we know about them at birth, and the cycloplegic refraction error is approximately around +2 diopters. This is universal, you know, there's nothing new in it. Now this hyperopia decreases rapidly by first year of life and gradually by 3 years when the eye becomes an e-metrope. This is one thing is important. Though in some eyes the reduction continues up to 12 years because there is still 0.3 millimeter of eye which keeps on after 7 years, it keeps on elongating up to 12 years. Just normally अगर 23.8 है तो वो 23.4 है 5 है तो 23.8 is the natural e-metrope we have, so it may be up to 2 years. There is also a higher prevalence of astigmatism at birth of 1 diopter or more. All types of astigmatism is seen which normally disappear by 4 years of age. Second thing, 30% of the newborns also have anisometropia, you understand that, which again disappears by 4 or 5 years. This transient anisometropia is due to different rates of emetropisation between the 2 eyes. ठीक है? Now, why this natural history is important? With spherical hyperopia greater than 3 diopters after 1 year, there is less than 50% of chance that it will disappear, which should normally do by 3 years of age. But if it is more than 3 diopters, normally 2 diopter hota hai, it should disappear by 3 years. But if it is more than 3 diopters, there is 50% of chance that it will not disappear. So it has a bearing later on, that's why. Isometropic bilateral astigmatism of more than 3 diopter at 1 year will not regress, because normally we have up to 1 diopter, but if it is 3 diopter, it will not disappear. And then it is amblyogenic. Myopia of more than 3 diopters at 1 year will never disappear, and this is the root cause for progressive myopia. Yesterday I had a keynote address on myopia symposium in the morning, yesterday morning, and there are a lot of people saying कि myopia में कोई ज़रूरत नहीं है, and you only if myopia progresses. Then I told them no. I was also on the chair, I said कि if there is myopia before 3 years of age, it is 100% going to be a progressive myopia. तो आप इसको disregard नहीं करना है, समझ गए? Infants with refractive error and strabismus have only 50% of chance of e-metrosis, again the problem. Similarly, if anisometropia of 1.5 or more, anisometropia, right? You should understand, of more than 1.5 persist after 1 or 3 years of age, there is a high risk of remaining and development of amblyopia. This is important. Now, what are the implications of this persistent refractive error aster 4 years of age? Normally, everything should become all right by 4 years of age, whether it is hyperopia or anisometropia or it is astigmatism. But what are the implications if it remains after 4 years of age? Now we start with the management now. Now hyperopia. Children who maintained 3 diopters of more of hyperopia after 3 years of age were more likely to develop esotropia. So here we have accommodative esotropia as a predisposing factor, right? Children with uncorrected bilateral isometropic high hyperopia, you should understand all these terms, have poor visual acuity. Astigmatism. The visual system is not very sensitive to astigmatism in the first place, agreed. But after that, uncorrected bilateral astigmatism of more than 3 diopters, particularly oblique, results in meridional amblyopia. With every diopter of increase of astigmatism, there is a loss of one line. And isometropia, correct? 1 diopter of more, now this is very important, you should note it down, do what, take a picture. 1 diopter of more of uncorrected spherical hyperopic anisometropia causes amblyopia and other related visual disorders. So, 2 diopters of more of spherical myopic anisometropia causes amblyopia. 1.5 or more of astigmatic anisometropia, hyperopic or myopic, causes amblyopia. Of all the visual functions affected, visual acuity, stereo acuity, it is more sensitive to anisometropia. So you should understand that hyperopic anisometropia, myopic anisometropia, and astigmatic anisometropia. These are all amblyogenic. You have to be careful. Myopia. Bilateral isometropic myopia of less than 4 diopters up to the age of 6 years is not amblyogenic, but and causes no visual distance. But after 6 years, the child uses both near and distance, because abhi to sirf khel ka play school mein near hai, but after that he starts distancing. And uncorrected myopia not only hinders visual activity, but is a stimulus to progressive myopia. So whenever a child comes to you before 4 years or 5 or 6 years with a myopia, okay, even a bilateral isometric myopia, it is 100% indication is going to go into progressive myopia. So you start with those drugs. We have atropine is number 1, pirenzepine, सब कुछ आपको start करना है. Antimetropia, it is not given in any book, but it is there. In the world knows about this. What is antimetropia? One eye myopic, other eye hypermetropic. But it is given in my book. Now, refractive error after 8 years of age. Now, after 8 years of age, the critical amblyopic age has gone. And in most cases it has gone. So, management is now directed to the treatment of the damage which has been already done. Understand that? So, what is the damage and what would you have to control? Amblyopia has resulted because the 7 to 8 years is the amblyopic age. Right, Suchita? So that amblyopic age, so then amblyopia has already happened. So now you have to correct the amblyopia, which can you do up to 12 years of age. Management of asthmatic symptoms and headaches occurring due to refractive errors. That is because of hyperopia and astigmatism. The art of managing spectacles. This is a big art, how to give spectacles in children. And management of progressive myopia. Now, when you give spectacle corrections to a child, you have to understand and look at these following questions and the queries. Is the refractive error within the normal range of the child? 3 साल के बच्चे को अगर -1 का वो hyperopia है या +1 का या estimate है, you will not be worried because it is not going to progress and not going to cause any problems. Is the refractive error, will it metropize? There are a lot of children who are coming at 4 years or 5 years, 4 years or 5 years, There are a lot of symptoms. आप लोगों को मालूम नहीं शायद the accommodative problems बहुत हो रही है बच्चों में भी because of the mobile and laptops. So there is accommodative problems, तो with that refractive error अगर है तो आप क्या करोगे उसको? So will you wait for it to metropize? So there are a lot of those conditions I told you before, they may not metropize. So you start the treatment. Is this reverter going to be present? Will this error disrupt the normal visual functions? अगर आप उसको 2 डायप्टर का हाइपरोपिया है, अभी भी चल रहा है, 4 साल की एज में आपने उसको ग्लासेस दे दिए बिकॉज यू डोंट नो, और वहीं मेट्रोपाइजेशन स्टॉप हो जाएगा. सो बिकॉज यू हैव टू हैव अ स्टिमुलस, बिकॉज हाइपरोपिया का 8 साल, 7 साल, 12 साल तक भी चलता है मेट्रोपाइजेशन. So you're not going to prescribe until and unless you have problems. Until you have headaches or asthma problems, or if the hyperopia is very high, 4, 5, 6, then only you treat the patient. So will prescribing spectacles interfere with the normal process of metroposition? That is, you have to, that's why I told you the natural history, which is important. Will prescribing spectacle interfere? When prescription of spectacles is required, is crisp vision more important or elevation of symptoms? Patient आता है, 5 साल का स्कूल जाने लग गया, 6 साल का स्कूल जाने लग गया, उसको वाटरिंग हो रही है, हेडेक हो रही है, पढ़ता नहीं है, दिखता नहीं है, and you find there is an astigmatism or there is a hyperopia, 5 है, 6 है, and if you go spectacles of 4 or 5 plus diopters, patient will not accept because of the good amplitude of accommodation. No, that is what you have to learn. That is what you learn. I can't tell you now because we are short of time, but I'll tell you the book. You can go read that and then you can know. So, but crisp vision, the vision is more important. If the vision is good, 6/6 हो जाती है अगर उसको correction से, the child is very happy. आपको, you know, the world has, there are so many records in the world and papers in the world where the child asks for spectacles as soon as he gets up in the morning. Because -3, -4 का myopia या astigmatism उसको एकदम इतना clear दिखता है, he feels so happy. So he immediately asks for spectacles कि मेरा चश्मा कहाँ. So crisp vision is more important. So first you have to correct the vision. It should be 6/6 and the symptoms will automatically disappear. Will the child accept glasses? Very important question. कई बच्चे चश्मा नहीं लगाते हैं. That is what is, you have to train. Now wait, stop, and this is my book. It's a 600 pages textbook, you know, which has been released by JP Brothers last year, and it's a full. A lot of medical colleges have already purchased, including medical colleges in my place, Jaipur, and also All India Institutes of RP Center, and also a lot of, because when I get the information of the royalty. So it is a full textbook on clinical pediatric ophthalmology and strabismus. So इसमें सब correction है. And all the how to correct in a child, refractive errors, amblyopia, everything is there. So you can buy it from JP Brothers, और जो आप लोग और interested in pediatrics सब clear हो जाएगा. ठीक है? Thank you. Thank you, Super. You can ask any question you.
No, it's not working. So, can you give certain advice, those who are novice, initially they are giving prescriptions?
Type of glasses का मैं समझा नहीं, मतलब what, you know, the material of the glasses?
Yes, mainly the material.
As a broad rule all over the world, you know, it is universal that in a child up to 12 years we always give a plastic lenses. But it is acrylic glasses, as a rule we give that. And then there are different, you know, what, see, मेरी इस book में it is also given as a big chapter on what spectacles to give to a child. Hypermetropia में क्या दोगे, thick glasses हैं, accept करता है कि नहीं करता है क्या, size of the glasses, the pentoscopic tilt. Lot of children, and you see, I've been, you know, for 40 years I've been going all over the country, you know, and abroad also. उसके बाद ये किताब लिखी है, you know, it's a big textbook. इसलिए लिखी है. इंडिया में कोई textbook नहीं है. It's all foreign textbooks which are more than 20,000 or 25,000. Suchita knows. This is the first textbook by an Indian author. It's very cheap. सिर्फ 4,500 की है. बाकी सब 12-13 वॉन न्यूडन की हो, चाहे केनेथ राइट की हो. I have all the books, you know, when I started this practice, but it is all 20-25,000. और ये पूरी कंप्रहेंसिव है, सिर्फ 4,500 की है. तो व्हाट आई वाज सेइंग, देयर इज अ फुल चैप्टर ऑन दैट. पेंटास्कोपिक टिल्ट, यू नो व्हाट इज पेंटास्कोपिक टिल्ट? No, you know the tilt of the lens. आपने बहुत बार देखा होगा चश्मा यूं हो जाता है, कभी यूं हो जाता है. So that tilt is very important. Should not be more than 7 degrees. नहीं तो astigmatic, वो मतलब उसमें prismatic effect आ जाएगा. लार्ज ग्लास, नो, हायर नंबर्स में प्रिज्मेटिक इफेक्ट आ जाएगा, जैक इन द बॉक्स फिनोमेना चालू हो जाएगा. सो यू टू शुड बी ओनली हैव ग्लासेस लाइक मी और दिस फेलो, योर ग्लासेस आर स्टिल बिग, एंड वो कोई हीरो के तो बहुत ही बड़े हैं ग्लासेस. देयर इज नो हीरोइज्म इन दिस. ओके, यू हैव टू हैव ग्लासेस which correct, you know, they should be in the center of the, one thing important is the eyeball should be in the center of the glass. Decentralization of the lens is very important. None of the optometrists, आप चाहे दुनिया भर के किसी भी चश्मा वाले भेजो, उनको मालूम ही नहीं है डिसेंट्रलाइजिंग क्या होता है. आप जो उसको पसंद आया पेशेंट को वो ग्लास दे दिया, चाहे वो इधर बाहर निकल रहा है, चाहे नीचे लटक रहा है, चाहे ये इतना बड़ा है. See, in higher numbers, wherever you go more than 4 or 5, decentering is very important. Otherwise, prismatic effect आ जाएगा. So the size of the glass, eye की position कहाँ होनी चाहिए, पेंटास्कोपिक tilt नहीं होना चाहिए. Then the position of the glasses on your nose. Normally it is 12 to 13 millimeters above. One other thing, आपने ऑटोरैफ से रिफ्रैक्ट किए. ऑटोरैफ रिफ्रैक्शन इज फ्रॉम द सेंटर ऑफ द, फ्रॉम द कॉर्निया. You see, it is from the surface of the cornea. Autoref is from the center of the cornea, and when you do with your retinoscope, it is from the retina. You see, so when now you give glasses जो कि 12-13 मिलीमीटर आगे लगते हैं, 4-5 डायप्टर तो कुछ नहीं होगा, उसके बाद इफेक्टिव ग्लासेस इसमें चेंज हो जाएगा. अगर आपका 5-6 मायोपिया है, so when you go higher, see what happens, you need more power. और अगर प्लस का है, यू नीड लेस पावर. तो ये जो 12-13 मिलीमीटर का जो आपका डिस्टेंस आता है, वर्टेक्स डिस्टेंस जिसको बोलते हैं, यू हैव टू टेक इट इनटू अकाउंट इफ यू आर प्रिस्क्राइबिंग हायर लेंसेज. एस्टिग्मेटिज्म में है 2-3 से ज़्यादा है, या हाइपरमेट्रोपिया मोर देन 5 है, मायोपिया मोर देन 5 है. दिस वेरी इंपॉर्टेंट. इसलिए नाक के ऊपर नहीं लटकना चाहिए जैसे इसका लटक रहा है चश्मा. ये अब मेरे सामने करने से क्या होगा? हाँ, so you know, if the minus spectacles go forward, the effective power of the glasses becomes less. आपको ऐड करना पड़ता है. आप कभी भी देखना, you know, I'm sorry, I'm taking a lot of time. बंद कर दूं? You see, because I have another session, so that's why. देखो अभी क्या होगा कि आपने -6 का -7 का मायोपिया इज वेरी कॉमन, यू नो, और आपने उसको स्पेक्टिकल दे दिया नाक के ऊपर, वो थोड़ा सा भी नीचे आएगा, यू नीड नॉट 6, यू नीड 7. पेशेंट विल ऑलवेज कंप्लेन कि साहब मेरे को दिख ही नहीं रहा है, दिख ही नहीं रहा. आप कहोगे नहीं मैंने तो बिल्कुल ठीक दिया, चश्मे वाला बोलेगा मैंने तो बिल्कुल ठीक दिया है. because of the vertex distance, the effective power in a minus lens become less, and a plus lens you need more. Less, I'm sorry, I mean. तो ये बहुत सारी चीज़ें इंपॉर्टेंट है जो डॉक्टर सुचिता पूछ रही थी ना, कि आप इसलिए पेशेंट को और बच्चे को तो क्या उसके माँ बाप को समझाओ कि ग्लासेस कैसे लेने हैं, स्पेक्टिकल. समझ गए? बाकी सब किताब में पढ़ना. बाय बाय.
थैंक यू सर. थैंक यू सर.
Thank you, sir. Our next speaker, Dr. Jyoti is here. Yeah. She'll be telling about prescribing glasses in children. What is the right way? Over to you, ma'am.
Hello everyone, I would be presenting on prescribing glasses in children. What's the right way? I think most of the golden points has already told. So objectives of my talk would be what are the age appropriate vision assessment methods, how we would go for cycloplegic refraction, a little bit of understanding about emmetropization, and what are the different guidelines for prescribing in myopia, hyperopia, astigmatism, anisometropia, and other special situations if time permits. So there are certain factors that we need to consider before prescribing. First is visual needs according to age of the child. How do we understand this? See, the For an infant, or for a kid of around 1 or 2 months, the kid would be more interested in neo world. He would be more interested in seeing the mother's face. So prescribing a -3 diopter to a 1.5 month old kid would behave differently to the same prescription that we give to a 12-year-old child, right? Then the second component we have to remember is all kids will have a very strong accommodative element, so that would mask certain types of refractive error, and by the time the kid presents to us, the child would have already landed up into amblyopia. The third point is we have to look for whether the child has a squint or not before we prescribe, because when I practice, I have this mindset that first thing I need to do is I have to rule out strabismus, because if the child has squint, I would make certain modifications to my final prescription. Another thing is age-related emetropization. We would learn about it a little later. And then the risk of amblyopia, because whatever prescription you give to a kid, you have to make sure that you are mitigating the risk of amblyopia. And then we should also take a systemic history of the child, whether he has Down syndrome or some developmental delay, because such kids will have accommodative lag. So accordingly, we need to prescribe. Coming on to age-appropriate vision assessment, why the visual acuity measurement has to be age-appropriate? Because children are in a phase where the eyes are growing, they are growing. So the visual acuity methods you are implementing has to be according to the age of the child that he or she is presenting with. Whenever a kid comes, we have to try to give them a comfortable position, and of course the mother's lap is the best position for a kid to relax and for an examiner to examine. So when the child is relaxed, you can do the baseline examination, torchlight examination, and if the child has squint, you can also do a cover uncover. By that time, parallelly, you can take a history, ocular history, systemic history, everything, and then you can design the strategy how you need to proceed further. So another thing is you always divide the patient into, you categorize the patient, whether the patient is infant, toddler, preschooler or school going, and accordingly there are a battery of tests available for measuring the visual acuity. For infants, we need to look for the fixation, whether it is central steady maintained or not. Optokinetic nystagmus drum is another technique with which we can assess whether the child has a good vision or not. See, the quantitative assessment of vision in infants is not possible as such. So whatever methods we are implementing is to assure that whether the child has vision or not, the child's visual pathway is functional or not, whether the afferent or efferent pathways are functional or not. For toddlers, I most of the times prefer Cardiff acuity test. Then for preschoolers, Leah symbol, K pictures are more popular. And as the child grows and they have little bit of understanding and comprehension, you can always go for Snellen's visual acuity test or logMAR chart. logMAR chart is more repeatable and preferable. Coming on to cycloplegic refraction. So a good retinoscopy is a gold standard. A good retinoscopy is a must, and atropine 1% is the gold standard cycloplegic. So preferably, in our center we do CTC. We most of the times do CTC protocol where we put 1 drop of cyclopentolate followed by 5 minutes के बाद में tropicacil, and then again after 5 minutes you put cyclomide and do a refraction of after 60 minutes or so. So the idea behind doing a CTC is the child need not come back again, and the effect would be lasting for 24 hours. So if the kid has some exam or some test to go, the child can always go. But if the only side effect with cyclopentolate is it causes certain neurological problems. So if the baby has history of seizures or developmental delay, one can always switch to homide eye drop. Another option for doing auto refraction in kids is photo screeners, and we can while performing retinoscopy we can also use this skioscopy racks or retinoscopy racks, and they are very good for performing retinoscopy, because most of the times the child will not allow to put a trial frame over their eyes. Coming on to emetropization, so the basic 3 refractive components of the eye is cornea, lens and the axial length. So emetropization is the process by which a normal eye has a coordinated growth of its refractive components during early childhood, and that would allow the eye to reach to near plano. And at birth, as Sir said, most of the infants would be hyperope of around +2 diopter, and they will have certain amount of astigmatism also. Until 2 years for hyperope, then this would be followed by a slower phase of emetropization, and until 2 years for the emetropization will go for 2 years for hyperope and 4 to 5 years for myopes. The rate of emetropization is considered proportional to the initial error, and it is usually completed by 6 to 7 years of age, and thereby myopic shift sets in. So these are the basic refractive components of the eye: the curvature of the cornea, the curvature of the lens, and the axial length. Coming on to the guidelines for prescribing, so we have different guidelines, the AO, APOS guidelines, and we have the AIOS guidelines as well. So the guidelines basically provide us with a framework or a foundation, but the actual prescription depends on your own clinical judgment and experiences. So as we look into this AO guidelines, we can see that the threshold for anisometropia is lower than the threshold for isometropia. Like for a child of 3 to 4 years of, for a child of some 1 to 2 years, less than 2 years of age, myopic child, you need to prescribe if it is isometropia of more than 4. But the same kid, if the child has anisometropia, one has to prescribe if it is 3 or more. So the threshold is lower when it comes to anisometropia, because it is the most common type of anisometropia can lead to amblyopia. Another thing is AIOS guidelines. These have been developed to address the local variation in the pediatric refractive error, and I personally find them more suitable, because when I deal with Indian population, I find them more suitable. So coming on to hyperopia, the first thing we need to see in a hyperopic patient kid is whether the alignment is ortho or not. If the child's eye are straight, I usually go for mild undercorrection to allow some emetropization to occur. And if the child has esotropia, I try to prescribe full plus, always give full plus and allow them to come after 6 to 8 weeks for a follow-up. In follow-up visit, again, if the child has less than 8 to 10 diopter, less than 8 to 10% diopters of ET for near and far, then we are sure that it is a refractive accommodative esotropia, and we can continue with the same glasses. And remember that if it is refractive accommodative ET, we need to prescribe full plus. And if the child on follow-up has more than 8 to 10% diopters for near and far, it means he has partially accommodative ET. So we have to plan surgery for the remaining amount of esotropia. And suppose the child has less than 8 prism diopters of esotropia for distance, but more than 10 prism diopters for near, then it is a non-refractive accommodative ET with high AC by A ratio. In such patients, you have to consider for executive bifocals bisecting the pupil. Always give full cycloplegic correction in hyperopia with ET. So when I say executive bifocals bisecting the pupil means that would be something that would encourage the use of near component. It has to be flat topped, and gradually the idea is to gradually reduce the power to increase the divergence amplitude. And with every visit you have to keep the patient on close follow up, and as the child grows, the bifocal power you need to reduce gradually. Coming on to myopia, so for more than 3 years, more than 4-year old kid or preschooler, you prescribe if it is more than 1.5 diopter, or if it is if the child is presenting with symptoms. The aim is to prescribe the lowest minus power needed for the best visual acuity. In a broad outline, myopia more than 3 years of age, -1 to -10, it is pretty straightforward. You need to give full correction. And coming on to astigmatism. For preschooler more than 4 years of age, prescribe if it is more than 1.5 diopter. In astigmatism, there is some confusion whether to prescribe full or keep them under correct. The general
doctor, just
yes,
yeah, you can just sum up and
okay. So the key points are: categorize the kid first as per age, then employ age appropriate visual acuity methods, do a cycloplegic refraction which is must, rule out squint before prescribing, and consider the role of emetropization and risk of amblyopia. Thank you.
Thank you for a very good talk. Just wanted to know, how do you wen up the patients, those who are having a ACA ratio, and you are giving them the bifocals?
Sorry, ma'am.
You are giving them the bifocals in those cases where you are having a AC by A ratio, high AC by A ratio. So what time, how frequently you call them, and when do you wen the glasses for these cases?
Ma'am, patients with high AC by A ratio, I basically work in a medical college, so I have only 2 or 3 kids to whom I have prescribed executive bifocals. If I call them to come after 6 weeks or so, they won't be coming. So most of my follow-up patients would come after 6 months or 1 year, or some of them would be lost. So, but the routine protocol I follow is to ask them to come after 6 weeks or so.
Thank you.
Thank you. Thank you.
So, do we have Dr. Venkatesh here? Yeah. So, Dr. Venkatesh will be speaking about pediatric cataract concepts and consideration. Over to you.
Thank you. Shall I start?
Yeah.
Very good afternoon to you all, to all the learned audience members and our faculty, and all my dear chairpersons. Today I shall be talking about pediatric cataract. I have no financial disclosures to make. Before I begin, I would like to pay a big vote of thanks to my mentor, Professor Sudarshan Khokar. Most of the work which I'll be discussing today has been derived from his book, Atlas of Pediatric Cataract. So we know it's the incidence is around 1.8 to 3.6 per 10,000 per year. And in the studies which have been done at our center, which is RP Center, developmental and post-traumatic cataracts are quite common. In one of our studies, we found that the developmental cataract incidence was actually more than the post-traumatic ones. Genes which are usually involved are alpha-crystalline, PAX6, PITX3, and the most common inheritance pattern noted was autosomal dominant. These are few pedigree charts of the same, and I shall directly come to the morphology. There's a morphological classification as well if it involves the whole lens, whether a lamella, it's a central cataract, or anterior, or primarily posterior, or miscellaneous. And here I'm showing you certain clinical pictures along with the associated UVM findings. Here you can see in picture A, there's a total white cataract and the associated UVM. In picture B, there's a Morganian cataract. You can see the sinking nucleus here as well in the UVM. In picture C, the lens volume has been lost because of egress of fluid from the microleaks, and you can see it's a membranous partially absorbed cataract. This is a lamellar cataract. This is a nuclear cataract, pulverulent or powdery cataract, ant-egg or cataract with calcific foci, cerulean cataract, sutural cataract like an inverted Mercedes-Benz sign, and other miscellaneous classifications like anterior polar, anterior subcapsular, posterior polar. These are all different kinds of cataracts which we have rarely encountered in our practice. This is a typical barbed fence wire-like cataract, though these are quite uncommon. The etiology, most of them are idiopathic. Hereditary causes include Down syndrome. These are few other ocular features like brush field spots which can be noted in them. Loewe syndrome is also associated, Nance-Horan syndrome, where we see long rectangular faces. Alport syndrome associated with anterior lenticonus, and Marfan syndrome. It's usually associated with subluxation of the lens with increased arm span, pactus carinatum, aortic root dilatation, high arched palate, long slender fingers, and revised Ghent criteria has been used to diagnose Marfan syndrome. Galactosemia is associated with oil droplet cataracts. Homocystinuria again is associated with lens subluxations and myopia. Wilson's disease with sunflower cataract, and infectious causes which are quite common in our country, torch infections, the most common of which is congenital rubella syndrome. We see typically these kids with microcephaly, microphthalmos, iris atrophy, polydilating pupil, and partially absorbed cataractus lenses. Anterior segment dysgenesis in the form of Peters anomaly is also noted to have these cataracts. Other morphologies and other causes include pre-existing posterior capsular defect, persistent fetal vasculature, which is a common cause of unilateral cataract, traumatic cataract, and uveitic cataract. Pre-existing posterior capsular defect is noted in cases of posterior polar cataract, PFV, and lenticonus. You can see here that there is a peripheral white dot sign because of the egress of the fluid and then rapid maturation of cataract. This is typically called as the white dot sign. You can appreciate the UBM of such a case where the lens is almost absorbed and there is a posterior capsular defect and there is lenticular matter in the anterior vitreous. Persistent fetal vasculature is actually a spectrum ranging from persistent pupillary membrane, mitten of dot, cataract, to vessels over the lens, and then posterior PFV includes Burgmeister's papilla falciform fold. Traumatic cataract can be due to open globe injury or closed globe injury. Uveitic cataracts are usually associated with juvenile idiopathic arthritis. They have other associated features such as posterior synechiae, band-shaped keratopathy. So how to approach these patients when they come to our clinic? We have to take a detailed history. The parents usually give a history of inability to make eye contact, squeezing of eyes, especially in bright outdoors, squinting of eyes, and abnormal ocular movements. Especially if the kids are older, they give history of inability to read the blackboard, bringing objects too close to the face, or sitting too close to the television to watch. And general examination is very important. As we have seen, there are certain metabolic causes associated with these cataracts. Like this is a case of microcephaly seen in congenital rubella syndrome. Leukocoria, whenever the kid presents, we have to keep other differentials in mind as well, including retinoblastoma, PFV, ROP, and Coats disease. And examination includes primarily doing a distant direct ophthalmoscopy first, having a good vision, good assessment of the red reflex. Visual acuity assessment has already been discussed in detail. Pupillary examination, very important, though very simple and old test, but works well because it tells you about the optic nerve health status. A Bruckner's test or a red reflex would give you idea about the opacity. As you can see here, fixation, very important. In pre-verbal children, a central steady maintained fixation can help you give a prognosis to the parents. If it is non-central, unsteady, not maintained, the prognosis will be guarded, and you have to tell the parents that despite the surgery, despite long follow-up, the kid may not gain vision beyond a point. Vision tests in infancy have already been discussed. We have been routinely using Cardiff visual acuity charts, which are preferential looking tests based on vanishing optotypes at our clinics, and more than 1 year of age. Primarily, these are candies and balls, the smallest of which a child can pick up, gives us an assessment of the visual acuity status of that kid. Ocular examination on the anesthesia table is very important because here we are doing the biometry. A scan, B scan, MRI, especially in cases of PFV cases. Here you can see a PFV stalk associated with a color Doppler showing the vasculature, and the MRI associated with the same, where you can observe that the globe is shrunken. It's a microphthalmic eye. You can see the PFV stalk as well. Laboratory investigations become quite important in conditions such as galactosemia. So it's a multidisciplinary approach. If a Marfan's patient comes to you, we have to send it to our cardiovascular colleagues. If a GIA patients come to you, we have to send it to our hematology colleagues. In GDD patients, peds neuroconsult becomes important. There have been a lot of talk about emmetropization, so I won't be covering that part, and change in axial length, which is attained to the adult level by approximately 5 years of age. So it's all a very organized process where there is increase in radius of curvature, increase in anterior chamber depth, and thinning of the lens. And simultaneously, there is an increase in axial length. Whatever opacity or any disturbance which causes disparity in this balance will lead to hyperopia or myopia. And active emmetropization also occurs because of feedback from our image clarity from the retina. So, examination under anesthesia. Smaller eyes, we should not put IOLs in such spaces. We have our own cutoffs. I will tell you about the same. Keratometry is very important, which should be the first step in the UA before we put anything over the cornea. Do not use a speculum, use a handheld keratometer. Axial length measurement, immersion A scan are the best. If not possible, you can use a contact A scan, but don't indent too much. Otherwise, you will be having axial length which is too short. Ultrasound biomicroscopy, if you can't afford, don't worry. It's a very good tool which helps you prognosticate, especially in cases which is having a posterior capsular defect. But clinical examination like a deep anterior chamber, white dot sign will also give you a clue about how to proceed with such a case. This is our UBM cups. In a water bath, we put the UBM probe and assess. It also gives us an idea about the white to white. Depending upon the white to white, we can actually determine whether we have to put an IOL or not. This is a UBM of a cataractous lens. And again, I'll show you a partially absorbed cataractous lens where most of the lens matter is reduced. There can be a posterior capsular defect. So we may have to use a multi-piece in such a case. I cannot proceed. Can you help? Yeah, I'll just take 2 minutes. Preoperative considerations and surgical planning. So we intervene in such a case when there is a visually significant cataract more than 3 mm obscuring the visual axis. There are abnormal ocular movements in the form of nystagmus or nystagmoid movements, squint, and obscuration of globe with a direct ophthalmoscope. A poor near vision is also a very good indication to operate and go inside these eyes. Timing of surgery is very important because there is a critical period of neuroplasticity after which amblyopia sets in. Unilateral cataracts operate as soon as possible, 4 to 6 weeks of age. Bilateral cataract at 6 to 8 weeks. But the problem is not the timing of surgery. The problem actually is the age at presentation by which the parents take the kids to you. Our cutoff at RP center is axial length more than 17 mm and white to white more than 10 mm. We proceed with the IOL. And there have been undercorrections described by Dahan, Prost, and NERD. We use our own nomogram, less than 6 months of age, 20% undercorrection, 6 months to 1 year, 15 to 10% undercorrection, 1 year, 2 years, 5 years, then 2% undercorrection. Choice of the IOL, hydrophobic square-edged optic as far as possible. And for optic capture, you can use a multi-piece. There was a study of unilateral cataract done in US in which they tried contact lenses versus intraocular lenses. Their profile was different, and they also excluded cases such as PFV, which is quite a significant proportion of our unilateral cataract population. They found that putting a lens before a certain age might lead to secondary complications like secondary glaucoma. But the thing is, in our population, most of the patients are from poor socioeconomic strata, consanguineous marriages, and they are not that educated as well. So putting an IUL might be a good option if they are not very compliant with spectacles and contact lenses as well. There are certain surgical challenges we have to keep in mind about the head position. We can use a shoulder roll and a head ring and appropriate size speculum, proper incisions. CCC runs off, so we have to use a heavier viscoelastic like a Helon GV. Anterior capsule management, as I told you, heavier viscoelastic than multi-quadrant hydro. And for posterior capsular access, a very important step, we do not need to fill the bag, just the anterior chamber, adequate enough to create a space for our ILM forceps or whatever forceps we used to go. It should be smaller than the anterior capsular axis, and an anterior vitrectomy is must, because if we do not cut this anterior vitreous, this can act as a scaffold for PCO formation. Our cutoff for doing a CCC is 7 years of age, but let's say if a kid of Down syndrome is there, if a GDD patient is there who cannot sit on YAG later, you can do a PCCC even after 7 years of age. IOL implantation should be against the anterior capsule in the bag, and incision closure with 10-0 is very important, and it is a low scleral rigidity tissue. We do the suture removal at 6 weeks, and post-op refractive correction with glasses is given. Less than 2 years of age, we give prescription for near. After 2.5 to 3 years of age, when the kid goes to the playgroup, we can prescribe for distance with a near ad. Executive bifocal is good in such cases. And in unilateral cataracts which have been operated, there is already a component of amblyopia, so we need a age-appropriate patching. In cases of severe amblyopia, full-time patching. In case of mild to moderate amblyopia, partial occlusion may be fine. So to sum up, PCO can be a complication which needs to be catered with PCCC. Early identification and early surgical intervention is must in this patient. IOL implantation in Indian setting does have a key role. PCCC less than 8 years of age is very useful. Suture placement, because the tissue is very elastic and having less scleral rigidity. Refractive correction, regular follow-up is very important. Amblyopia therapy and management is key. And regular follow-up. The surgery per se is not the job. The job is the follow-up. And parent counseling before the surgery, that the kid would require long follow-up. There might be a need of research in the form of a membranectomy if VAO develops, or IOL exchange later if there is a refractive myopic surprise when the kid turns old. And there are certain post-operative complications as well, like VO and glaucoma, which should be managed appropriately. So I thank you all for your kind attention. Thank you so much.
Thank you for a very broad, elaborative talk.
Yes, ma'am.
Just one thing, you had written VP. So in which cases do we routinely do a VP in all cases?
No, we do not do routinely VPs.
So where in which cases are you actually asking for a VP?
Cases of long-standing RDs. There are a lot of patients which come after ROP with secondary cataract. Patients with long-standing RDs in which there is no visual potential. If there is a high with high hypotony, we would like to do a VP to know whether there is any prognosis or not. If there is no prognosis, there is no point in going inside that eye and let the eye go into phthisis eventually, or maybe not having any prognosis at all.
Okay. Also, knowing that you have a RD and it's a long-standing cases, so just to prognosticate those cases, you will be advising. But usually, it may not help also if you...
Yes, ma'am. And it's not easily available as well.
So that point I just wanted to clarify, because
Yes.
Routinely none, even if you have a RD,
Yes,
also there is not
It's
a
just-
must that you can,
it's
you
just for
needs
an-
to be
it's
done.
just for-
Yes, for a documentation, for something you can ask for it, but already
not for
the
routine
prognosis
cases.
is...
It's just an add-on for such cases.
Yeah.
Thank you. Thank you for your kind listening.
Thank you. Do we have Dr. Amit here? Dr. Devang? Dr. Anuradha? Okay. Do we have Dr. Siddharth? Yeah. So Dr. Siddharth will be speaking about recent trends in management of retinopathy of prematurity.
Good afternoon, everyone. So At the outset, I'd like to thank AIOS for giving me the opportunity to present this talk. Retinopathy of prematurity, as we know, is a vasoproliferative disorder which affects the preterm babies who are underweight with low birth weight and who are obviously born preterm. So we need to focus more on the babies who are under 2000 grams, because that is the RBSK guidelines we are following, because we need to cover most of the babies because of their increased survival and the NICU care that we are having these days. Their survival is increased, so there is increase in the incidence of ROP we are noting. And to be focused is the very extreme low birth weight babies less than 750 grams who need to be screened early at 2 to 3 weeks of age, because they are at more risk of developing aggressive ROP. There are various algorithms which are predicting ROP development based on the demographic profile of the babies, their gestational age, birth weight or sex, and even AI enabled tools are reasonably capable of predicting the ROP development. So these can be used by the pediatricians to refer babies to ophthalmologist. We are well aware of the zones and various stages of the ROP. To be focused here is the zone 1 and posterior zone 2, where if the ROP develops in this zone, it needs to be aggressively managed because it is sight threatening. So to just summarize, we have stage 1 where we have a demarcation between the vascular and the avascular retina. When this gains a height, it becomes a ridge. So this is a stage 2. Eventually there's a stimulus from this hypoxic retina, the increased VEGF load, which causes the retinal vessels to abnormal retinal vessels to grow into vitreous cavity, and that is the formation of the stage 3. Eventually there's a partial retinal detachment, and eventually the retina detaches. So it's stage 4 and stage 5. Once there is a dilatation and tortuosity of vessels at the posterior pole, this is the predictor of the aggressive ROP. Now this aggressive ROP is also noted in anterior zone 2. So that is the why the terminology is now changed from aggressive posterior ROP to aggressive ROP. And this is the disease that does not progress through the conventional stages of ROP and needs to be tackled early. So the management guidelines for ROP are based on the early treatment ROP cooperative group, where zone 1, any stage with plus disease needs to be treated, be it stage 1, 2 or 3. Zone 2, stage 2 and 3 with plus disease require treatment. All other can be followed up. And for the convenience, we have for management, we have type 1 and type 2 ROP. So zone 1, any stage with plus disease, or zone 2, stage 2 or 3 with plus disease is a type 1 ROP. It requires treatment. Type 2 can be observed. So the treatment of ROP, as we know, the pathogenesis lies with the hypoxic retina, which is stimulus for the VEGF. So we require anti-VEGFs, lasers or surgery. Now anti-VEGFs are the preferred treatment option for ROP, and these are predominantly used in aggressive type of ROP. This is the recent study, which was the survey which was conducted involving 54 ophthalmologists from 11 countries, and each of the ophthalmologists were routinely screening about 394 babies per year. So based on their response, these were from the developed and the developing countries. However, India was excluded, but based on their response, this is the preferred pattern which we are even following in India. So this is the preferred pattern. So most of the ophthalmologists for aggressive ROP, type 1 ROP in zone 1 and type 1 ROP in posterior zone 2 were using anti-VEGFs. Laser was used for the disease in anterior zone 2 or zone 3. Laser is a definitive treatment, but it is routinely being recommended and being preferred by ophthalmologists once the anti-VEGF has been given to treat the persistent avascular retina, or once the disease recurs. Mostly the ophthalmologist was not giving a repeat injection once the recurrence is noted after first dose of anti-VEGF. So preferred anti-VEGF being used by majority is bevacizumab in half the adult dose. So BEAT ROP study and Rainbow trial have given the evidence that anti-VEGFs can be used for ROP. Ranibizumab has been approved after the Rainbow trial for use of for its use in retinopathy of prematurity, and it's continues to be a off-label use in other countries. DCGI approval has also been given for ranibizumab. So in our practice, we are using ranibizumab mostly because it is a one-dose vial which is available. Avastin has cost issues. There's a problem of dividing. The parents have to be convinced that the entire vial has to be used for single time. So they may not be convinced, but the efficacy of bevacizumab is much more as compared to ranibizumab. So the injection has to be given in the OT setting. We have to, usually a bilateral injection is given because the disease is mostly symmetrical, and the injections may have to be given in the ICU because it's the babies who cannot be transferred. It's not that we leave untreated, and sometimes the babies who are systemically more sick, anti-VEGFs do better than laser because the children, that's a painful procedure, it's a long procedure, they may not be able to handle, so anti-VEGFs are relatively safer. So as I discussed, most of the respondents were preferring bevacizumab, and aflibercept, only the 3 of the respondents out of 54. It has an advantage, it's a long duration of actions, yet there are limited studies for its use. So aflibercept, not a routinely recommended anti-VEGF. So bevacizumab is preferred in developing countries, as I mentioned the reasons, because of the cost, the recurrence, and the ease of administration, one dose vial available, which can be divided in both the eyes. Ranibizumab is being used in developing countries. 0.2 milligram, we're using 0.25 milligram in 0.025 ml. So that dose does better than 0.1 milligram dose of ranibizumab. So this I have already discussed. So ROP occurs more frequently with ranibizumab treatment. So it was observed that about 40% of recurrence in anterior zone 2 was noted with ranibizumab. However, when bevacizumab was given, about 10% of the babies has recurrence in zone 2, and about 2 disc diameters of persistent avascular retina was observed in less than 10% of babies who were given bevacizumab. Aflibercept is still very limited use. There's increased popularity of anti-VEGF since 2019 because I discussed in unstable babies with unstable systemic conditions, anti-VEGFs are preferred, they are safer, they can be given under topical anesthesia, but the risk of endophthalmitis, so it is always better to be given in trained hands because you can have intralenticular injections, you can have RDs, so that is not to be taken lightly. So this is the table which I have referred from the study which has been published in 2024. So what we can see is the anti-VEGFs have been used commonly in aggressive ROP in zone 1, in zone 2, type 1 ROP. So this is one of the preferred pattern from the clinicians. So babies, less than 20% of the infants who were being treated, 34% of the clinicians wanted to give them anti-VEGFs. However, we can see the number of anti-VEGFs being given is increasing, has increased considerably since the pandemic. So laser, as I told, it is used for disease which is in anterior zone 2 or zone 3, and it is used for babies who come with recurrence after first dose of anti-VEGF. So this is ultra wide field angiography which has now taken its importance in the diagnosis of ROP and to follow up. So this we can see that there is a persistent, there's a avascular retina in zone, you can see a demarcation line, and once given the anti-VEGF, the vascularization has progressed. So this gives, Optos gives a 200-degree view, unlike the RedCam which gives 130-degree view. So this is underutilized but can be used in babies who have been given anti-VEGF. So we can see the avascular areas here, we can see the aggressive ROP and various neovascularization and the ischemic scapulin, the non-perfusion areas in the periphery. So point to be noted here is FFA can give a guide for targeted laser in babies with ROP who have been given anti-VEGF. So not to laser the entire avascular, but this is a limited availability, costly instrument to take the pictures in a flying baby position. So in our routine practice, if we feel there is a avascular retina after anti-VEGF at 10 to 14 weeks, it's better to go ahead with laser than to, because the follow-up may be a problem and the babies will grow older. So that I have already discussed. Stage 5, limited, many babies are not subjected to surgery when we have a closed funnel RD. So but we have seen that when there is a stage 4A ROP, lens sparing vitrectomy, the mobile visual acuity can be achieved in about 50 to 75% of cases. So all babies need not be operated. It's the decision of the treating ophthalmologist. And stage 5 babies, just to have maybe from hand motion to a finger counting vision, that can be achieved, but not all babies have to be operated. It's just from case to case basis. So anti-VEGFs, follow-up time frame about 55 to 60 weeks we have to continue follow-up, and there is no consensus on follow-up guidelines, but you can follow up these babies as long as 1 year, because recurrence has also been noted at 6 years in one of the cases. So long-term complications need to be taken care of. Myopia, this was a child who received ranibizumab and she had about minus 12 diopters of refractive error. So it's not that the anti-VEGFs result in high myopia, it's the not just the lasers, the anti-VEGFs can also result in high myopia, though they are mostly causing a moderate myopia. but high myopia has also been noted. Squint has to be taken care of. Regressed ROP babies can also have myopia, squint and isometropia. So it's a long-term follow-up. Stereopsis is better in babies who have treated ROPs than the ones who are not treated. Neurodevelopment delay is not definitely proven with anti-VEGF, so they are relatively safer as on date. So at the end, I would just summarize that parent knowledge is important. Baseline refraction have to be done in all babies. They can have multiple systemic anomalies, so their hearing, neurodevelopmental assessment, and the neonatologist has to be kept in loop because their weight gain is important, anemia control is important, because if it's not there, then the ROP won't regress. So the weight gain, anemia control has to go hand in hand with this. Thank you.
Thank you. A very elaborate discussion you have given. So just one question. Had there been any follow-up of anti-VEGF with the laser, long-term follow-up of visual acuity till now, or it is still ongoing, or we are not at a stage to say which will have a better visual gain?
What we have noted is it's a theoretical discussion because the visual field defects are more common in babies who undergo confluent laser and who have a disease in zone 1. So if there is aggressive ROP, because all may not be giving anti-VEGFs. So if it's a zone 1 disease, laser is a definitive treatment. So people may be just going directly ahead with laser. So if there's a large area which is lasered, because anti-VEGF gives a time for the vessels to grow and the limited retina has to be
No, it's like we are still following up and we
yeah,
don't
they're still
have
following,
the
because I have not
results,
come across any study
yes.
which is definitely giving the visual acuity quantification. So that I think has to be seen.
Yeah.
Yeah.
So maybe in the next few years we'll be coming up with it, because more we are going into anti-VEGFs and
Yeah.
less are into the lasers now.
Yeah.
So what is actually having in the long term, 5 years down the
Yeah,
line and 10
because
years?
2019 only
Yeah,
this has
yeah,
the
that
trend
is
has
the
come
thing.
up. Yeah, you're right. Thank you.
Any side effect have you encountered
No,
with?
no side effect. We have touchwood not seen any case of endophthalmitis, no lens injection, and plus disease immediately goes off in the
Yeah.
next day. We can see the response is visible, but in about week to 10 days, it usually disappears. Thank you.
Thank you. So anyone else is there? Just call once more. Any presenter who is absent is there? So thank you all the speakers. We had a good discussion and it is quite a wide variety pediatric ophthalmology. So we want all the speakers to come to have a photograph.